Good day. You are at our next, which I don't know, is this now episode 4?
4, I think it's 5.
Yeah, of the Modern Women podcast for ATP Science. You're with your temporary host, Elizma, today. And we've got Danielle and we've got Nicole. And we are very fortunate to be interviewing Lara Briden, who is definitely someone I look up to a lot when it comes to hormones. Definitely, she is the guru on a lot of this stuff. And today we're going to talk about ovulation, menstrual cycles, birth control, all of the stuff that a lot of you women out there maybe want to know a bit more about, what the differences are. As we've kind of said to you earlier, Lara, Danielle's a nutritionist, both me and Nicole are naturopaths. But tell us a little bit about yourself and your background, Lara.
Yeah, I trained as a naturopathic doctor in Canada, hence the accent. Even though I consider myself Australian in many ways, because I lived there for 15 years. I'm originally from Canada. So I trained in Toronto, Canada as a naturopathic doctor. I worked in Canada for about 5 years and then moved to Sydney in 2001. And I was there a long time as a Sydney naturopath. And during those about 15 years, I became more and more focused on helping women with period problems and thyroid and perimenopause. And from that point, I, about 4 or 5 years ago, decided to put all of what I'd learned about period health, including years on the ground with patients, into a book called Period Repair Manual, which first came out, it's early 2015. It's been through another edition. It's been, yeah, it's great. It's reached women all over the world. So I kind of thought it was a book for my Australian patients, but turned out it's actually a book for everyone because women all over the world have the same kinds of problems.
Absolutely. And you're also on quite a few, when I had to Google you, you've got your own Wikipedia page, which I think is so cool. I mean, it must be a sign that you've kind of made it. So you are also serving on a couple of councils as well, is that right?
Yeah, so I'm on the advisory board for the scientific advisory board for this, called the Center for Ovulation Research at the University of British Columbia. That's headed by Professor Geraldine Pryor, who's a reproductive endocrinologist who helped me with Period Repair Manual, who's my mentor, who I look up to, and a lot of her quotes end up in my work. And then I'm on the sort of expert board for the Endometriosis New Zealand, because I live in New Zealand now.
Yeah.
So,
But you do still travel from Sydney to Sydney from time to time?
Well, I had been up until this year.
Everything's
changed, but I had been coming to touch base with my Sydney patients about 4 times a year and doing a little clinic intensive in Sydney, which was also a good chance for me to connect with Sydney friends.
Because you do.
I don't know when I'll get there.
Because you lecture pretty much all over the world and do quite a bit of traveling.
Yeah, for sure. Yeah.
Awesome. All right, so let's get things started a little bit, and I guess I'm going to just for the listeners out there run a little bit quickly through what kind of like happens through a cycle. Obviously, your period starts on day 1 is the first day, which is the day of bleeding. Then sort of like after that, and that's also the time where your hormones, I believe, is at their lowest level, is on that day 1. And then
menopausal levels. I just say it's normal for estrogen to be so low at that time. Because a lot of women get their estrogen tested and they're like freaking out that it's so low, but that's normal. Day 1.
And is that also the reason why a lot of women kind of may feel a little bit more depressed and irritable, sort of like around that time, because of that low hormonal level?
In part, I think in part, yeah.
Yeah, all right. And so then sort of like from day 1 to day 5, that's kind of when the follicles start to develop in the ovaries. And then sort of like from day 5 to 7, I believe one follicle will kind of survive. The rest will sort of like, I guess, disintegrate or not develop. You have that one follicle that develops that kind of like, stimulates more estrogen to be released.
Well, there's eventually, a bit later than day 7, but there does become a dominant follicle in that follicular phase, which eventually does suppress it. Look, follicles there's waves of follicles developing all the time in the ovaries. Most of them get reabsorbed and amount to nothing. But if a cycle is functioning properly, yes, there'll be a dominant follicle.
Yep.
And that can take a lot more than 14 days. That follicular phase, that pre-ovulatory phase, that's where a lot of the variability can happen. So in younger women especially, that can be easily 3 weeks, and that's normal.
Right. So ovulation does not always necessarily happen on day 14.
Absolutely not.
And I think that's important to know, because especially if you're, for contraception purposes, if you're not taking birth control or anything like that, and you kind of guarantee, you just kind of like look at that day 14 time frame.
Oh, you can't do that. No, you have to be a little more scientific about understanding when your ovulation's actually happening.
Absolutely. Because even like during that ovulation, an egg can also survive up to 48 hours, correct? And then sperm is about 5 days in the reproductive tract. So there's a lot of, there's a fairly big window there where it is possible to fall pregnant.
It's about a 6 or 7 day window in total, which is actually not that big if you think about it. Men are fertile every single day. Women are fertile really only 7 days per cycle, 6 or 7 at the most.
Right. So, but it is like you said, you've got to be a little bit more scientific. So do you kind of like, do you like the idea of women kind of like, I guess that's what I want to ask you. So in order to check for ovulation, how do you kind of like tell women to monitor their ovulation? Is it through temperature checks, or how do you kind of do that?
Temperature. But let's just kind of finish the cycle. So normally in a by definition menstrual cycle, ovulation occurs, and then there's a 2-week, almost exactly 2-week luteal phase, which is the post-ovulatory phase. And that duration, that can't vary really, because it's dictated by the lifespan of the corpus luteum, which is the temporary gland that forms with ovulation.
Yep.
And it is possible, this is very important, I think, for women to understand, you can have what's called an anovulatory cycle. So you can have essentially just a super long kind of follicular phase where nothing happens, no dominant follicle happens, but the existing follicles make estrogen, and you build up a uterine lining, and then eventually that kind of shed somewhat randomly, although it can look kind of on time. So that's called an anovulatory cycle, and that's really important to understand. Whenever patients or readers are asking me what's going on with their periods, as you might have seen me on social media and in my book, I'm always constantly asking, okay, did you ovulate? Did you ovulate? That's like the very first question to understand anything about the cycle. And in answer to your question about how do you know that for certain, you check your basal body temperatures. It's a perfectly scientific method. It's as certain as doing a blood test for progesterone in the luteal phase, which is the other way to confirm ovulation. But you get this progesterone, the hormone we make after ovulation, raises body temperature by about 0.3 degrees Celsius.
All right.
Consistently for that. So it's a biphasal. So you get this 0.3 degree rise after ovulation, and it stays high until the end of the luteal phase, and then it drops, and that signals that your period is going to come the next day. And if it doesn't drop, you're pregnant. This is called body literacy. Like, this is actually something girls should learn in don't you agree? Like in junior high school, it's like this is how our bodies work.
Yeah.
This is how you know if you ovulated. And you could take that a step further and start to try to use that to avoid pregnancy. But even if you never go down that path of using it to avoid pregnancy, you can still understand what your body's doing. And suddenly what seemed like irregular periods become a lot more predictable, because you know as soon as you ovulate, guaranteed, absolutely 100%, you're going to get a period 2 weeks later, a bleed 2 weeks later, or you're pregnant.
So that's interesting. Like the luteal phase, you say it doesn't change. That's pretty much constant. But it's that follicular first phase that can either be shorter or longer. So when we have a female with an irregular, so not the typical 28-day cycle, we have to look at that first follicular phase to what's going on. Is that correct?
Correct. Well, first we look if they're ovulating or not, because an anovulatory cycle is another explanation for an irregular cycle. It's not really a cycle. If it's anovulatory, it's actually not really a menstrual cycle anymore. It's just breakthrough bleeding or kind of random bleeding. But if ovulation is occurring, then yes, the variation is in the follicular phase, and that's how you talk about it. That's what you look at.
Yeah. So I kind of like that you say that, because I've always wondered, how much estrogen plays a role in a lot of this stuff, because we often look at, I used to look at it that maybe there's too much estrogen in terms of if the cycle is irregular, that it's always got to do with too much estrogen. And then I realized, no, it's actually usually too little, because you need that estrogen surge to get the luteinizing hormone going, right?
Correct. I think, to speak about hormones and ovulation comes first and the hormones follow that. I mean, yes, our main estrogen goes into sort of a feed forward cycle to reach ovulation, but think of it this way, like if a woman believes she has very, very low estrogen, a young woman, it's because she's not ovulating. The only way to make estrogen is for the follicles to go on that journey to ovulation. And if they reach ovulation, if ovulation occurs, then by definition, there's enough estrogen. And there can be too much estrogen, but that's not going to impair ovulation. And if you don't reach ovulation, there'll be no progesterone. So it's not that a lack of progesterone is causing a problem with ovulation. It's the fact you didn't reach ovulation, therefore you're not making progesterone. So it always comes back to if you're not ovulating, why not? There's always an explanation.
Wow. I love that you talk about that. Now I get now what you're saying about ovulation being like the center. Because I always used to look at it from an estrogen and progesterone point of view, and
no,
it's not.
You're not thinking about ovulation, the central event. Ovulation is the central event, and if you're not thinking about that, nothing else makes sense.
Yeah. And I think it's also, about anovulation, that's also quite important, because a lot of women think just because they have a period, they can fall pregnant. But if, you can have a period and you can still not be ovulating and still not be necessarily fertile. But is it the other way around as well, Lara? Like, can you also ovulate and not necessarily have a period?
No? I just had a big conversation about this on Twitter. No, except, so I'll just say, so ovulation comes first, and then 2 weeks later, either a bleed or pregnancy. That is written in stone, like that is guaranteed, unless the only situations where you can ovulate but then not go on to bleed are, well, obviously if you have a hysterectomy or an ablation or something to the uterus that prevents bleed. Like if you don't, don't have a uterus, you can still ovulate but not bleed, right? That's an obvious example. The other example, when you can ovulate but not bleed, is the hormonal IUD, which is one, because it works by thinning the uterine lining. So you can have no bleeds on the hormonal IUD, but still track your temperatures and see that you're cycling and ovulating.
All right, so does that mean that you can still fall pregnant if you have an IUD?
No.
Because of the uterine lining, right? Because it's not thick enough.
Yeah. So it prevents pregnancy in another way, but it does permit ovulation. Which is interesting.
Yeah, that is definitely is interesting. What about women who, who are breastfeeding, who may not have a cycle? I've heard like there has been of occasions where women fall pregnant. They didn't think they would be able to fall pregnant because they just had a baby. They're breastfeeding.
Okay, so ovulation comes first, and then the bleed 2 weeks later. So if you haven't, let's say you're in the scenario of breastfeeding, haven't been ovulating for months and months and months, but then you do ovulate and you fall pregnant that very first time you ovulate, you will fall pregnant without ever seeing a period.
Right. So if you didn't, then you would have seen a bleed like 2 weeks later.
Yeah.
Yeah, right. That makes a lot of sense, actually.
That's really common. You know what else that can happen is recovering from undereating.
Yes.
For example, maybe you haven't had a period for 2 years. You could fall pregnant without ever seeing a period if you're having sex, because you could fall pregnant the very first time you ovulate.
Yeah.
I've seen that happen lots of times. And the problem is young women, like if they sort of think, okay, I'm not having periods, so therefore I'm infertile. And if they're not getting the right information, they might just think, oh, well, I don't have to worry about condoms or anything like that. And it's like, oh, actually, I'm 4 months pregnant. I went from having amenorrhea to, I realized I'm 4 months pregnant, never saw a period.
So in terms of, now that we sort of like get an idea of what the cycle is, we know how important ovulation is. What happens when there's like breakthrough bleeding or spotting in between cycles? Is that like sometimes to do with hormone fluctuations, or is there other reasons why some women may get like sort of like spotting in between cycles?
Oh, there could be all kinds of reasons for that, actually. That's, again, it's coming back to the question of, are you ovulating? First question, if you're seeing spotting, is like, are you ovulating? That's the very first question. There could be, it's normal to get a little bit of ovulatory spotting. That's just from a slight drop in estrogen with ovulation. You get a little bit of breakthrough, the endometrium sheds a little bit. That's actually normal. Then if you're not making enough progesterone, you can get some spotting coming through in the luteal phase. If you have endometriosis, you could get spotting just purely from the endometriosis, or if you have polyps, or if there's probably 10 different reasons you could be spotting, and they're not always hormonal reasons. They could be kind of more structural reasons.
So fibroids, definitely I've seen that happen as well. What about if estrogen levels drop in mid-cycle, because I believe that estrogen kind of stabilizes the uterine lining. So is it possible that if estrogen levels, let's say, is lower, like let's say perimenopause or anything like that, could that also cause some kind of spotting or breakthrough bleeding?
Okay, estrogen's going up and down all the time. Like its normal trajectory through the cycle is some big ups and downs, and there's always a dip. It always a drop around ovulation. So that's a common reason for a bit of mid-cycle spotting. Perimenopause is a whole other topic, actually. It's
a big one, yes.
I just finished writing my second book which is going to be about perimenopause. You can have me back next year to talk about it.
Awesome, definitely.
Basically, short answer, during perimenopause, we can have up to 3 times more estrogen than we did when we were in our 30s.
Oh, wow.
So it's a situation of very high estrogen. It's actually, going up and down. I call it the estrogen roller coaster. So you can have some dips, but again, generally running at quite high levels of estrogen. Spotting in perimenopause could be from fibroids, from anovulation, from thyroid, from, spotting is actually a big topic. That does require, many of these things you can't do on your own. You do have to ask the doctor, is my thyroid okay? If I'm not ovulating, is it because I have insulin resistance?
Yeah.
In Period of Perimanual, I call our period the monthly report card. So if everything is going well, you ovulate every month. If something's not going well, you don't ovulate. And then it's about looking back, why, what's not going well? What is the thing that what does my body need to be able to do this?
And Lara, what would you say are some of the main things that you see where women, that ovulation will be affected, that could be happening in their life, whether it was recently or even months before that time?
Yeah, exactly. So there can be a time delay.
Yeah.
There can be, so if you had a big stress, excuse me, like a big emotional trauma or something, your periods could go all wonky a few months later. Everyone's periods after this, what's happening to us right now is everyone's periods are going to be all weird.
That's true.
Definitely.
And then I guess it's up to the doctor needs to then rule out some maybe less common things like hyperlectin, thyroid, celiac disease, like go through the list, certain medications. At the end of the day, the 2 big ones are, and they're often confused for one another, which is strange, but anyway, the 2 big ones, because they're quite opposite, are insulin resistance and PCOS, kind of in the same category, insulin resistant PCOS.
Yeah.
And the second thing is undereating. And young women losing their periods to undereating, or I'm going to say undereating carbs, is common. It's more likely to happen to women under 30 or women who spent a lot of years on hormonal birth control and so who didn't mature their menstrual cycle. The communication between their brain and the ovaries are more sensitive. Women who have a very robust cycle, meaning they've been cycling for 10 years, they've got it. They're, we grow into our cycles. Professor Pryor, who helped me with my book, uses the term robust menstrual cycles. I love that.
Yeah,
like if you're in your
great
mid-30s and you've been having regular cycles for 15 years, a little bit of undereating isn't going to be a big problem. Your body will be like, it's fine. But like if you're still have quite an immature menstrual cycle, it's quite sensitive to a lot of things. You can get thrown out. So undereating is the big one. Stress, again. Nutrient deficiencies, I'd say. I see, well, I don't know what all your views are about a vegan diet, but I see women losing their periods on a vegan diet.
Oh,
and,
yeah.
Absolutely.
I'm trying to gauge my audience when I bring that up.
No, we're pretty moderate here, Lara. We're the common sense brigade, It's not about the extremes, but more the moderation.
Yeah.
So that's very, very interesting, because I've seen patients like this who have had the undereating, so extremely thin, overtraining, and then end up with the PCOS, insulin resistance.
Label.
It's very very typical, and we usually think that they should be overweight, right? These women.
Okay. Yeah. This is a takeaway for all of your listeners and for anyone. Pass it on. The problem is the ultrasound finding of polycystic ovaries, and if you guys follow me on Instagram, go and look at what I posted yesterday about that. Okay, that finding of polycystic ovaries means absolutely nothing. Like, it does not mean PCOS. 100% does not mean that. And it's quite common for women with undereating, or what's called hypothalamic amenorrhea, to have polycystic ovaries on ultrasound and be mistakenly told they have PCOS, and then Google PCOS and find out they need to cut carbs and then eat less.
Oh, yeah.
And what do you think is going to happen to her, that young woman getting her period back?
Yeah, absolutely no.
Yeah. She's never going to get her period back. And it's very concerning, and it's a big mess, basically. It's happened because of the fact that PCOS has a terrible name. It's not polycystic ovary syndrome. It's nothing to do with cysts on the ovaries, like absolutely nothing. So the name needs to be changed. It's a misunderstanding of what the condition is. It's the fact that ultrasound technology is getting better and better. So we're zooming in on these ovaries, seeing these follicles or eggs, which are normal for the ovary and normal for a young woman to have tons of them, tons of eggs, right? Because they're a young woman, and labeling that polycystic ovary. And then that's where it all falls apart.
Yeah,
absolutely.
I think I did read that maybe a couple of years ago, that the definition of polycystic ovarian syndrome, it's changed, at least in our field. I don't know if it's changed in the medical field, but where the presence of cysts on the ovaries was not a diagnostic measure anymore. Would you say it's more to do with the insulin resistance and the androgen dominance? Would they be more diagnostic, I'd say, or for PCOS?
PCOS
is that a bit of a tricky question?
No, it needs to be explained. It's a diagnosis of exclusion.
Okay.
So basically, this is my official definition, which I think should be adopted, but anyway, this is what I call it. PCOS is a situation of having excess androgens, hormones, when all other explanations for excess androgens have been ruled out.
Right.
And that would include things like adrenal hyperplasia, high prolactin. Those are the things that cause high androgens. So if you've got, it's not normal to have high androgens. It's not normal to have facial hair. So that is definitely a situation, a problem with the hormonal system that exists. But unfortunately, even once you fall into that category of the diagnosis of exclusion, everyone agrees, yes, you have high androgens, so that's a problem. You may or may not be ovulating, probably having anovulatory cycles, although not always.
Yep.
Then the next question, and this is why I have my four subtypes or functional types of PCOS. The next question is, why do you have high androgens? Like, what's the underlying driving factor? Because that's what we need to fix. At the end of the day, we need to help those women not be dialing down their androgens, be making fewer androgens, and regaining ovulation is part of that, because the estrogen and progesterone we make by ovulating have natural anti-androgen effects. And they help to regulate the communication between the brain and the ovaries in a way that turns down androgens.
Right.
Yeah.
So here's something, this might help you guys. So all of us, part of the developmental phase of maturing into a menstrual cycle is, as a teenager, to go through a temporary phase of essentially PCOS. So we become androgen dominant, slightly insulin resistant, when we're like 13, 11, 12. You know how 11-year-old girls have that kind of abdominal thickening?
Yeah.
It's normal.
Yeah.
So they're becoming a little androgen dominant at that stage. Then that's part of it's a step they have to go through, and they start making lots more hormones, but then they also start progressing towards ovulation, and then their estradiol and then their progesterone kicks in. And progesterone helps to modulate that communication between the brain and the ovaries. And then that's when androgens go down, and that's when you get the hourglass figure, and you kind of move through like into the more estrogen progesterone cycling phase. So if you just back to the topic of birth control, you put a 13-year-old girl on the pill, especially on a high androgen pill, like one of the ones that contain levonorgestrel or some of the progestins that are a lot like testosterone, you're kind of locking her into that phase.
Yeah, so like that androgen dominant phase.
PCOS could kind of be seen as kind of a stalled puberty, if you will. Anyway, it's one way to think about it.
I've never thought about it that way. Yeah, so that makes so much sense. And there's a lot of girls who are being put on birth control at that age, sometimes for the contraceptive purposes, but also sometimes because, I guess all periods when they start, they can be a little bit irregular. Some girls may experience, heavier bleeding. And so a lot of them get put on it to try and control the period, right?
Okay, I'm going to ask you guys a little survey. Can the pill regulate a period?
No, absolutely not.
Because a pill bleed is a drug withdrawal bleed and not a menstrual cycle.
Exactly. Yeah.
In fact, it makes it harder to have a menstrual cycle eventually because you didn't get a chance to mature your menstrual cycle. So if you are on the pill from 13 and you come off at 31, you may not be able to ovulate straight away.
Absolutely. Yeah, we've talked about this before, haven't we, girls? How the birth control pill is just there to stop something, or it can't regulate because it's just
it's a suppression, isn't it?
But unfortunately, a lot of them do get put on by medical professionals for that purpose. So
and then they believe that they are having...
future generations are going to look back at that practice of routinely putting girls on the pill and be like facepalm.
Oh, absolutely. I can't wait for that day.
What were we thinking? It is. I'd say it's very wrong to do that to a girl. And as you know, there are other solutions for acne. There are other solutions for heavy periods. There are other solutions for avoiding pregnancy, even for a teenager.
No, I'm glad that you kind of like pointed out. So, I mean, we've had a bit of a thing about it that none of us really like the use of, we should say, hormonal contraception. I mean, obviously there's barrier methods, which is fine if that's what you want, to use. But for the audience out there, can we maybe run through a couple of different oral contraceptive methods and how they work? So for instance, we've got the Mirena, things like the Mirena, which are more like intrauterine devices.
There's just three I'll break it down into three methods, and then we should quickly survey the non-hormonal methods, which also includes the copper IUD. It's really worth mentioning that at the beginning. Okay, so there's either combination, in terms of hormonal methods, there's the combination methods that have a progestin. They all have a progestin, which is not progesterone. Progestins and progesterone are very different, actually.
Yeah, I'm glad you brought that up. Yeah, so how are they different, Lara? Like the progestin is more like a precursor to androgens and progesterone, or what's the difference?
Okay, no progestins convert to progesterone. Okay. They're completely separate molecules, and the word progesterone is not a generic term like estrogen that can refer to anything vaguely. Estrogen is a term you can refer to anything vaguely estrogenic, like anything really, like plant estrogens or estrogen technically. Progesterone is very precise. It's the progesterone the corpus luteum makes. It's one thing. It has one structure that has many benefits, which we won't go into because that would take half an hour. But one of the main benefits is it converts to a neurosteroid called allopregnanolone in the brain, which is highly beneficial for the brain. And no progestin does that, which is why probably women who take hormonal birth control have altered brain structure compared to women
I think I did read something about that, and I thought I think there was a certain area in the brain that was smaller in women who.
The hypothalamus is smaller, and women who take hormonal birth control, other parts are altered too. That's probably temporary, just to say, in case people are freaking out. I think once you go back, start having ovulatory cycles and making progesterone, your brain is going to change to some extent. It's something happened to the brain during those years that might not be reversible.
Yeah.
So, but in answer to your question, what are the different types? Most of them suppress ovulation, so they have that in common. But in terms of the basic types, you've got the combination types, which have a progestin of various sorts, which can either be testosterone-like or anti-testosterone, but none of it is progesterone, and none converts to allopregnanolone to help the brain. But what you do is, if you've got a combination method with estrogen, and that can be most pills, not the combination pills, and the NuvaRing patch, they induce a drug-induced withdrawal bleed. So when you kind of dose estrogen on a monthly basis, which you don't have to do, like there's no reason to do it that way, but you get this withdrawal bleed, which is not a period.
Yeah.
So there's that category. Then you have progestin-only methods, which can be either the implant, the injection.
I think there's a mini pill as well, isn't there? Like a mini pill.
The mini pill, the progestin-only pills.
Yeah.
So they don't induce a drug-induced bleed because they're not giving estrogens. So instead, what you get are just anovulatory cycles. They suppressed the ovaries to the extent that the ovaries still make some estrogen but don't ovulate. So you just end up getting kind of estrogen up and down anovulatory cycles. That's essentially what's happening on any of those methods. Apart from, the only one that's different is the hormonal IUD, which is such a low dose that it does permit ovulation usually after the first year when the dose of levonorgestrel, the progestin, is lower. And then you can start to have ovulatory cycles, but not bleed, which is quirky, right? So just to compare and contrast with the pill, or a combination method like NuvaRing or the patch or the pill, you get a withdrawal bleed from the synthetic estrogen, but your own hormones are flatlined, are zero. You measured the hormones of a woman on the pill, there's zero. There's nothing happening. So with the pill or combination method, you get a bleed. You bleed but don't cycle. And with the hormonal IUD, you can cycle but not bleed, which is strange.
Yeah. and then what about your intrauterine device? Because you get the hormone ones, and then you get the copper IUDs, and
they're completely different.
Yeah.
So
do you see? So do you see a lot of problems with women who, in my practice, I've seen a lot of issues with women who had the copper IUDs. Where it's just not working as they get a lot of side effects from it. Is that something that you see in your practice as well, Lara?
I have to be honest, big picture, I still think the copper IUD is better than any hormonal methods because it doesn't castrate you hormonally. So there's that, right? It lets you cycle, which is a big plus.
Yep.
Now, I personally know a couple of naturopathic doctors who use the copper IUD as their method, so that's kind of interesting.
Yeah.
It's not ideal. I mean, it's in many ways it's barbaric. Think about it. It's
well, it's something that they put into your uterus, right? Like a T-shaped rod
So just to clarify, because a lot of young women in Australia, this is my experience with my patients, have actually literally never heard of it. Because it's not mentioned to them.
Yes.
So I'll just say it's a piece of plastic and copper that looks about the size of an earring that the doctor inserts through your cervix in office. It's not surgery, although sometimes they use a local anesthetic, sometimes a general anesthetic, but usually they just pop it in, which is not comfortable. But once it's in and can last, depending on the type, up to 10 years. Now, the side effects you see with it are... It makes periods heavier, about 20% heavier. But if you started with light cycles, that's not a problem usually.
Yeah.
It alters the microbiome of both the vagina and the uterus, which is kind of, of course, when it was invented back, 60 years ago, no one even knew about the microbiome.
Yeah.
It wasn't even we ever considered. It does alter the microbiome, which to me, both types actually do. Anything you put in the uterus is going to alter the microbiome of the uterus, which is a little worrying. Some women, you probably get a tiny bit of copper from it, but honestly, you probably get more if you eat a lot of dark chocolate like me. Like we do get some copper coming into the body. So I don't know if it's the copper so much, but some women do get an anxiety reaction from both IUDs. And part of it with the hormonal IUD is that the drug levonorgestrel, the progesterone, causes mental health problems, can cause mental health problems. But the fact that the copper IUD also can create anxiety, my pet theory, this has not been proven, or even researched, it's sitting in the uterus, bumping into the cervix sometimes. Like it's right there, right? Like it's a structure. Yeah. The cervix is actually a fascinating structure that has 3 separate nerve supplies, including the vagus nerve. The cervix is actually really involved in orgasm and all kinds of things. Like it's actually quite centrally located in our nervous system, if that makes sense. Like there's a lot going on there. And when I think about it, like having a string through the cervix and a little pokey thing bumping into the cervix, I'm like, maybe for some women, the body's just like, I don't know what's going on right now. I don't like that. So that has totally not been scientifically researched.
No, but I hear what you're saying. Because I think I was once, offered that as birth control, and my instinct was just like, no, I don't want anything up there. I don't want anything in my body or anything like that.
To be fair, a lot of women love it. Just to be fair, because it is, you don't have to think about it, and it's nice that way. And it does permit ovulation. Which, going back to everything we're talking about, I'm a cheerleader for ovulation. If it permits you to make your big monthly dose of progesterone, then that's a big pro.
Absolutely, So even, that kind of like puts ovulation also at the center of prevention of osteoporosis and things like that. We always just looked at that as estrogen, but it's like, well, no, if you're ovulating, regardless of whether you're having a period or anything like that, then that will also help and protect the bones as well, correct? Without having a cycle?
Yeah, so Professor Pryor, endocrinologist, has a quote that I always quote, which is that 35 to 40 years of ovulatory cycles, as in making progesterone as well as estrogen, helps to prevent osteoporosis, cardiovascular disease, dementia, and breast cancer. And she states that quite boldly because progesterone is quite friendly to the breasts. It's several lines of evidence suggest that it helps to prevent breast cancer. Paired with, it's kind of the counterbalance, it is the counterbalance to estrogen. So that seems quite important.
Absolutely, definitely. And so again, it makes that thing like you can have a menstrual cycle, but if you're not ovulating, you're not going to get that bone protection that, from ovulation.
And ovulatory cycles, you're at risk of not getting the progesterone you need for bones. And just to be clear on the topic of breast cancer, progestins, this is another difference between progestins and progesterone. So I just stated that several lines of evidence suggest that progesterone helps to reduce the risk of breast cancer. Progestins increase the risk. In fact, the modern understanding of hormone replacement and kind of hormone therapy for menopausal women, and trying to understand what went so wrong with some of the types of hormone therapy they were using in the 90s, it's now mostly blamed on progestins. The breast cancer risk was from that.
And not necessarily from that's fascinating. You girls want to jump in with some questions?
I
feel like I'm dominating you.
Lara, I was going to ask you around, I know we touched on definitely one of the easiest ways to track if we're ovulating is through that basal body temperature tracking, as you said initially. What other ways do you like to, I guess, test hormones and to see what may be the imbalances for women in terms of their menstrual cycles? So do you predominantly use blood testing day 2? Is there a certain day, that you prefer? Yeah,
I do a lot of day 2 blood testing. Because here's what I might get on day 2. It is FSH and LH, those pituitary hormones, because that ratio between LH and FSH is actually very helpful to distinguish between PCOS, or insulin resistance, which classically has a high LH, compared to FSH, and undereating, which classically has a low LH compared to FSH. They should be about 1-to-1, ideally. So on that same day, you can do prolactin, you can do androgens. So I would do testosterone and a hormone called sex hormone binding globulin, which is hugely important for women. Hugely important. That's the protein that binds up testosterone. To have any kind of conversation about androgen excess, you need to know about SHBG. I probably measure DHEAS, the adrenal androgen. It's another potential androgen that can be high in women with PCOS, especially the adrenal type of PCOS. You can measure, lots of this the doctor could be doing, the doctor probably should have been doing, but yes, you could order it as well, which is something called 17-hydroxyprogesterone, which is a measure for, it's a test for called adrenal hyperplasia. It's a genetic condition that causes high androgens, which often it affects about 1 in 100 women and sometimes gets missed and misdiagnosed as PCOS, which is actually quite important.
But estrogen and progesterone on that day too, that will typically be low, right? So there's no real point in measuring that.
There is no reason to test progesterone on day 2. Only time, actually testing progesterone is tricky. Because as we've discussed, you only make it for 2 weeks at the most in the cycle, and the final 2 weeks. So if you have someone with a longer cycle, there's no point in doing a day 21 progesterone, for example, because they won't have any. So you have to ideally wait until they know they've ovulated. Maybe by tracking temperatures, then test progesterone about 5 days later. But honestly, if temperatures have gone up, you already know she's making progesterone, so you probably don't have to even test.
But can you, let's say, for instance, if someone has a 40-day cycle, because you would normally do day 21 on a 28-day cycle, which is kind of 3/4 in, can you take someone with a 40-day cycle, if they're not necessarily measuring their temperature, and go 3/4 into a 40-day cycle? No, doesn't work?
No. It's only the last 2 weeks. So with a 40-day cycle, you measure progesterone on day 33.
Right. Okay, there you go.
It's not proportional. I'm glad you asked it that way. I'm like, I might even do an Instagram post about that. Like, no, it's not proportional. It's the only time you make progesterone is literally the final 2 weeks. Nothing before that.
I think that's probably my I have to say, I'm learning so much from this. That's definitely the thing that I'm going to really take away from today, is that it is that last bit is the same. It's the beginning that everything is variable or changes.
And sorry, Lara, I was going to ask as well then, because often I've heard a lot of practitioners talk about testing luteinizing hormone to see if someone's ovulated. Is that a way that you have utilized in the past to see if they get that luteinizing hormone spike to then initiate potentially that progesterone estrogen production?
Yeah, with urine tests. Is that what they're using? The urine test strips? You can track luteinizing hormone. If you've got a really long cycle, that's going to be frustrating because you might end up getting... And if you've got PCOS, you have chronically elevated LH. So that'll be a false positive.
Exactly.
But just to clarify, I'm so glad you kind of explained it that way. Like proportionally, do you test 2/3 of the way? No. So there's the whole concept of mid-cycle is not helpful because it's not mid-cycle. It's ovulation, which if you've got a 21-day cycle could be quite early. If you've got a 45-day cycle, the mid-cycle doesn't mean anything. What matters is ovulation. So if you've got someone has a short cycle, like a 21-day cycle, which is common during perimenopause, you're probably ovulating on like day 7. If you've got a 45-day cycle, which is normal for a young woman, you're ovulating on day 28.
All right, so Lara, I know that you've got very limited time with us this morning, so I guess to kind of like wrap it up, I guess, is there like preferred ways, do you have like preferred ways of birth control or I should say contraception, not birth control, contraception that you normally recommend to your clients that you feel more comfortable with?
So I have a blog post called The 5 Best Types of Natural Birth Control. So people can look there and I'll list them as well. And I'll preface it by saying what we really need are some new methods to be invented because it's 2020 and we have self-driving cars and we still have the same birth control from the 1960s. Like, nothing's really happened, which is crazy. So there's a couple methods out there which are hopefully going to be come to market, which are not approved yet. One is a method for men, which is
it's about time that they have like some role to play in all of this, So
so it's a This is called Vasal Gel. It's an in-office, like in the doctor's rooms, injection into the vas deferens. Then however many years later, if a man wants to have babies, he can have a second injection to wash it away. It doesn't interfere with his hormones or anything. He still doesn't interfere with semen. It just stops the sperm from going into the ejaculate. So that feels kind of obvious to me that should be embraced. Yes. There's a couple other methods for women coming which don't affect hormones. Why we should have to shut down the entire hormonal system to prevent pregnancy is insane.
Yeah, exactly.
So at the moment, the non-hormonal methods we have are fertility awareness method, which you alluded to right at the beginning, and that's using scientific observations of temperature and or cervical fluid to know your 6 days of when you're fertile and abstain or use barrier methods during that time. So there's that. There's all the barrier methods. There's condoms. And it's worth pointing out that I don't know what your experience is, but with the young women that I speak to, a lot of them have this strange idea that condoms don't work, which I find very disturbing.
Yeah, agree.
Really disturbing. So they're doubling up. They're having, I need the pill plus condoms. It's like, no, you don't. If you're using condoms, that's a method. And I guess for what it's worth, I will say, I think for a young woman, teenager, condoms, and then access to the morning after pill. Because honestly, if there's a broken condom, you're so much better off just having a one-time dose of the progesterone. And also rather than taking a daily dose.
Absolutely. And also condoms protect against STIs and STDs and things like that, right? Exactly. Where birth control will not. So I agree with you. I think that's a much better method, especially for young girls early on.
Absolutely, and make sure they've got access to good quality ones. Condoms come in different sizes now. There's a few brands where they acknowledge that, and getting the right size, kind of like having the right size shoe. Right, you're going to have fewer problems. It's not going to break. It's not going to fall off as often, or hopefully at all, with the right condom and a good quality one too, and not one that's been sitting there, for 10 years,
deteriorating.
Exactly.
For condoms, the copper IUD, which we talked about. There's some other methods. There's a new diaphragm and a cervical cap, which are barrier methods for women, which are not as effective as condoms. There's also withdrawal. I have to mention it because it's a thing. It's certainly a lot of couples use that for years. And if it's done properly, the trick is to not have sex twice in a row without the man peeing and peeing his penis and all of that. But otherwise, that's a valid method.
Awesome.
Absolutely.
Anything that you girls want to ask or finish off with?
Look, there's so much we want to ask, but the time has gone so fast.
I know, the time has gone really fast.
No, you go this one.
No, I was done.
Yeah, I was just going to, I think we just mentioned Lara's book again, The Period Repair Manual. I think it's a fantastic book.
It is.
If anyone wants to learn some more about that, even for practitioners, I found it to be really helpful as well. So, but it's really great to for people to understand how your body works and cycles and ovulation and that sort of thing. So I think that's a really great thing to pick up if you can.
Absolutely. Definitely. And definitely, if you're finishing off the book and all of that next year for with it all about perimenopause, you'll definitely would want to chat about that.
I'm very passionate about perimenopause now, but we'll stay on the topic of younger women today. So I've got Period Repair Manual. I've got my blog, which is reasonably active, Lara Briden, and all my social media at Lara Briden, where on Instagram I do talk quite a lot about all these issues, the powers of ovulation. My favorite hashtag on Instagram is right to ovulate.
Love that. That's a great hashtag. I've definitely seen that.
You know what it comes down to start to consider women's hormones as an asset rather than a liability. That needs to be switched off.
That's such a great way of putting it.
Yeah, definitely.
Well, Lara, it was amazing having you on. I've learned a lot about hormones. I'm sure our listeners is also going to learn a lot from this. And we also have a lot of naturopaths, I think, that listen to the podcast as well. So they'll love this episode. Right. Well, Lara, so thank you so much for your time. Enjoy the rest of your day. And you got much better weather than what we've got out here from the images you showed us.
Yeah.
And looking so forward to catching up with you again in future.
Yeah.
Thanks so much, guys.
Thanks so much,
Pleasure.
Lara.
Thanks,
Thanks.
Lara.
See you, Lara.
Okay,
Bye.
take care. Bye.
Bye.